at this computer.
Okay, it looks like we are recording. So welcome to our week 3 live session. This will be one of the only live sessions that I'm actually holding this term. So there's a lot of stuff for week 3. I'm going to share my screen and just kind of jump into this because if not, it's going to take us like an hour and a half to get through all of this stuff. So I'm going to share, not that screen. Just hang on, wrong screen. I'm going to share this screen. Okay. Okay. So, like I said, I'm just going to jump into this for week 3. So here I am. I'm in Blackboard. Excuse me. And so I'm on the content tab. And if you scroll, I'm just going to scroll down to week 3. So weeks 1 and week 2, they're both pretty light in terms of assignments. I think there's only 2 assignments. There's a discussion post, and then there's like a quiz for each week.
Oh God, look at week 3. Holy cow.
Week 3 is a lot. Yeah, week 3 has 5 different assignments, and we have a resume, which most people find difficult, a resume and cover letter. And it's the first week of the portfolio project. So, yeah, week 3 can hit you pretty hard. Week 3 hits most people pretty hard. So just expect that. As far as, I'm just going to go through this. Okay, so week 3 live web call. If you're on the call, you don't have to enter the completed reflection. I'll enter your attendance and you'll get the points for that. If you're watching the recording, you will need to complete a written reflection for the week 3 live web call and turn that in as an assignment for week 3. And that should just be, I think it's 150 words, just kind of a recap of what you learned on this live session. But again, you won't have to do it. Those are on the call, since you're on the call. Okay, next interactive lecture. So here's your interactive lecture, and then there's also the lecture document. What I suggest is for every single week, make sure that you're downloading. You click on that docx file.
I do that every week. I do it every week.
Good. Yeah. And download it because there's no textbook for this class. So if you don't have that, you kind of don't have anything to study. So good. Okay, next discussion. I'm going to skip the discussion. We're going to go back to that here in a minute because I want to go through the rest of this. Week 3 resume and cover letter. So let's look at this one. So I'm going to click on this. Most people kind of, unless you already have a resume and a cover letter that you're happy with, a lot of people have a hard time writing a resume and cover letter. The whole point of this assignment is to make sure that you get it done, right? The whole point of this program is for you to learn a profession and hopefully get a career in this profession, right? And so part of this is just making sure that you have a working resume and a cover letter that you can add on to that you can use in the future, right? So 2 different parts. It does have, you need to do a resume and a cover letter. Cover letters for me can be kind of more, I have a resume, right? Like I keep a resume. I update my resume every year. At the beginning of every year, I update my resume. And I would definitely suggest that everyone do the same. You never know when an opportunity is going to fall in your lap, right? And you want to be up to date. So, but for me, the cover letter can be kind of more difficult. So I like to try to have students think of the cover letter as kind of like a personal, an introduction to who you are, almost like a little personal commercial to a certain extent, right? Like, so the resume has your work experience, your education, your whatever else is on it, your skills.
So I have both. I generally take the information or the job that I'm trying to apply for. I drop it into ChatGPT or whatever.
Yes.
And then he puts together along with, he kind of, because I have a my brain is not even working right now. I have like a base cover letter and then the information that I'm dropping about the position that I'm looking for. And then he puts them together, I revise it, and that's what I send out.
Yeah. So no, that's perfect. Yeah.
Okay.
Yeah. And that's what I like to talk about a lot when it comes to the resume is if you've only ever had, let's say you've managed a hotel, right? Or you worked in housekeeping, or you worked in the restaurant industry, or whatever, right? And you don't have any medical or healthcare experience, right? Try to pull out the parts of the experience that you do have from working in the hospitality industry or working in, managing staff in a restaurant, whatever the case may be. Try to pull out all of those relevant little components that,
Okay.
or all of those components that are going to be relevant in healthcare, right? Organization,
Right.
managerial experience, answering the phones, you know what I mean? Customer
That's where
service,
Chat
all of that
GPT for
stuff.
me comes into. That's where he came into.
Right.
That's where that was helpful.
Yeah.
So I mean, I've got that already. So that's not going to be a problem for me. That I
Okay.
could probably drop in there tonight and be done.
Good, good. I mean, I think you have Chat GPT is probably a good suggestion. What I would say for anyone else who's watching the recording is just make sure you proofread it, right? Like don't just
Right.
let Chat GPT dump in a bunch of stuff. It should be, I always get students who ask if it's like, should it be a real resume? Yeah, it should be a real resume. It should be a working resume. And it should be something that as you can continue through this program and you get your certification or you get more experience, you add to it so that it's a working document. A resume should never just be one and done, right? Like it should be a working document that you continually update.
Right.
Um, okay, so as far as the assignment goes, there is this is the detailed directions. This link, we have an example here, and then there's some skills. So I would suggest make just kind of looking through those and making sure that you incorporate that. Absolutely use a template for your resume. I'm also going to the announcements. I posted a couple of tips here. Um, in the skills section, make sure sometimes students forget to add all of the skills that you're learning in this program. You're learning CPT, HCPCS, ICD-10-CM, ICD-10-PCS, medical billing, HIPAA, all of that stuff. So make sure you add that skill section with everything you're learning in this program. Make sure it's ordered chronologically with the newest stuff to the oldest. Make sure you add this certification section. Whenever I hire a coder or anybody, the first thing I look at is, are they certified? Right. And as a coder, um, that's the most important thing is your certification, right? So you really want to highlight that. And you don't have to be certified in order to get a job. There's plenty of places out there that will hire either newly certified or newly graduated professionals, right? Coders. So if you don't have that certification yet, you can do something like this on your resume where you have a certification section and then you have CCA expected August 20. Oh, darn, I thought I changed that to 2026. Should say 2026 or whenever you're expected to take that 2020, that CCA examination, just so that that prospective employer knows that you are planning on taking and getting that certification. What else? Use a template and then, yeah, review all those documents. Your resume must include your information. Do not just use some template that you get and like post it like, hey, here's a resume. It should be your resume. So again, it's supposed to be, oops, hang on, was this the right? Yeah, we're good. I'm in the right course. It's supposed to be something that you can use as you graduate, add to it as you complete your program. And then when you graduate, you've got a resume ready. Okay, any questions about the resume before I go on to other stuff?
No.
Okay. Okay, resume. I'm going to skip the portfolio and come back to that. Check-in. The check-in is, I believe it's supposed to be 75 words or more. It's really just a summarization of how you're feeling about your progress so far. Do you have a book? Are you going nuts? Are you going crazy learning this new language? Or kind of how you're doing, right? So that's just kind of a brief check-in, just so I can kind of get a pulse on how everybody's feeling.
Okay.
And then, okay, so that's that. Let's go back to this portfolio project. Okay, so portfolio project, you're going to have a portfolio in weeks 3, 4, and 5. We're going to skip week 6, and then it's going to come back in week 7. So for weeks 3, 4, and 5, you're going to have, essentially what we're doing is we're following this patient, Jane Smith, and we'll look at what's going on with her here in a second. So she's coming to the doctor, and we're going to code out one of her encounters on week 3. Then week 4, I think she gets some labs and imaging services. We're going to code those out. And then week 5, she gets a surgical procedure. And so the way it's going to kind of work, right, is we'll talk about the portfolio project here in a second, the specifics. But You'll complete week 3 portfolio project and turn it in. I will grade it and provide you with feedback. And then what you want to do is incorporate that feedback for week 3. And then you're going to do the same thing for week 4. You do the same thing for week 5. And then when it comes to week 7, you're going to turn the whole thing back into me, weeks 3, 4, and 5, and then update your codes. So like if you got a diagnosis code wrong, or if you missed a level on your E&M code or something, right? Adjust that so that when you turn it back in week 7,
Correct.
everything's beautiful. And then you'll complete like a little written reflection, just like a paragraph of a reflection on the process. So that's kind of how it works, right? So weeks 3, 4, 5, and then it's going to come back in week 7. The thing is, it can be kind of hard to find all of these documents. So for week 3, you will complete a portion of your portfolio project. For detailed directions, please refer to the portfolio project directions and rubrics document available in the course assessments folder. Okay, but then you have to access the encounter note. Here's a link below. So if I click on this encounter note below, I'm going to open it up.
Hold on, let me get back into that. Do I go into view instructions?
So yeah, not
Yes.
yet. So
Okay, I
when
see
you
it.
go in here, right, if you click on this link, it's just going to bring
Uh-huh.
you the note, and you're like, this is an encounter note. What do I do with this? So keep that open. But what you're going to want to do is go to this course assessments folder. And it is in the content tab of Blackboard.
Hold on,
Course
let me get back there.
assessments, for me, it is down at the bottom. But if you don't like it there, you can always like click and drag these to reorder them. But course assessments, click on that. And then you're going to have a section here for portfolio project directions and rubrics. Click on that, and then here's way more links, right? So again, course assessments, portfolio project directions and rubrics, and then you're going to have all of the necessary links below. So I'm going to click on, it says, you will complete parts of your portfolio project throughout this course. Please download and print the document below to keep track of all directions and deadlines. And then you have this directions. So I'm going to click on this directions document. Okay. Sorry, the top is kind of cut off a little bit. So here's our directions, our portfolio directions and rubrics document. First things first, the portfolio is worth 20% of your grade. There are 4 components to the portfolio, so each weekly component is worth 5% of your grade. You have our course. I'm going to skip some of this stuff. Okay, so the scenario. You're working in a physician's office as a certified medical coder for ABC Medical Group. As a medical coder, you're responsible for reviewing patient medical documentation, identifying what information needs to be reviewed and taken from the documentation, and then assigning the correct code or codes that are supported in the medical documentation. One of the important reasons for accurate code assignment is to ensure that services rendered are reimbursed appropriately. So we're not just coding them out. There are going to be kind of different components to each one of these weekly
Okay.
templates or weekly portfolios. We're going to look at CCI edits. We're going to look at some different procedural coding. We're going to look at some different modifiers. So again, it's kind of, it's more of a wholesale review of what it's kind of like to actually code these out. All right, so for this project, directions, you will review medical documentation, which is provided in Blackboard. We already opened one of those up, right? You'll identify E&M service codes, CPT procedural codes, modifiers, and HCPCS codes if applicable. And you will record the identified codes in the coding template that we're going to download in Blackboard. And then for each deliverable, you will add additional codes to the template, and then the completed coding template will serve as your final portfolio project. I really can't overemphasize the use of the template because the template, not only does it make it easier for me to grade, but I'll show you what it looks like here in a second, but it's got little boxes and you don't know what to answer unless you're using the template. So it never fails. I'll have a student at least one each term who doesn't use the template and they miss components because they're not answering the questions, right? Because they need to use the template. So again, going back to Blackboard, this portfolio project directions, you're going to have a link here for portfolio project coding template. Click on that. And this is our
So this
template.
is where all the writing goes, right?
This is what you're going to turn in. Yes. So this is going
Okay.
to, and you're going to enter your answers in these little boxes. So you have
Okay.
week 3 for Jane Smith's encounter, week 4 for her imaging and pre-op labs, week 5 for her surgical procedure, and then week 7, and then you'll complete the reflection down below here. So ultimately, you should only be turning in
One at
one
a time.
document. Yeah,
Yeah.
one document. And you're gonna, yeah, turn it in week 3, add to it, fix it, then turn it in week 4, fix the other stuff if you need to fix anything, add
Right.
to week 4, right? And then it's the same document. It's kind of a working document, right? That we flip back and forth.
Right. Week
Um,
7, do we take everything out of the boxes and like write a report on what it is that we found and what we did? Or do we
no,
just turn in the what's there?
yes. So make sure you leave everything in here because I still have to grade it. I have to regrade everything. I want to see that you got
Okay,
all the correct
I
codes.
got it. I
And
got
then
it.
week 7 is you will also write a reflection on what you learned completing the portfolio project. So you just kind of write, most students just write it below right here, and
Okay.
then just turn it all in one document.
Okay, perfect.
Okay, so let's do it. Let's do week 3. Um, and the reason why I say to use the template is because the questions are here, right? You don't know what I'm looking for in terms of answers or codes if you don't know what question you're answering. So hang on a second. Let me open up one more thing here because we're going to use it. I did post a recording for the E&M coding last week. So I know E&M coding is difficult, so we're going to do a little bit of practice on E&M coding this week. I don't have my book, but I think it should be fine. Okay, so let's just look at the questions first, right? We don't know what we're even looking for until we look at the questions. So number 1, what is the appropriate CPT evaluation and management code if it's determined based on the time spent? Okay, so now we're looking for, what we're looking for here is an E&M code. We're going to look at that encounter note. We're going to identify the E&M code if it's determined based on the time spent. So I'm going to go back here.
Gotta find
Yeah.
it. Okay.
To our encounter note. Let me get my book really
Right.
fast. Hang on a second. Okay. um, okay, so if you have your CPT book, go ahead and get that out because we're going to find this code, right? Now, when we
Okay.
are coding for an E&M encounter, and if you watched the recording last week, then this should hopefully be familiar, right? An E&M is an evaluation and management office visit. Um,
Right.
I say office visit, but it can happen in the emergency department. It can happen in the inpatient, skilled nursing facility, inpatient hospital. It could be a consultation. It could be a preventive medicine service. There's all sorts of E&M services, right? So the
Right.
first question we have to ask is what type of service was this? And I'm going to type it in here. Okay. The second question is what was the patient status? I'm just going to type all this out. Status and then setting of service. Okay, so the first question is what is the type of service? Well, was it a consultation? Was it an emergency
Just follow up.
department? What was it? So let's look
Okay.
at the note. It says Jane Smith, 55-year-old female, presents to my office for a follow-up regarding recurrent carcinoma of the left breast. So it's an office visit, right? It's an office visit follow-up. So for the type of service, I'm just going to put office. When it comes to patient status, that's when we have to identify the patient as new or established, inpatient, is it a subsequent or is it an initial inpatient service, right? So in this case, we have to figure out, since it's an office visit, we have to figure out if this patient is new or established. So if we go back to this note, second sentence says, She was last seen in my office when she completed treatment 2 years ago, but experienced recurrence following a recent screening mammogram revealing suspicious calcifications. Okay, so she was here in this office 2 years ago. So do you know what's the cutoff for new versus established patient?
Like 18
No.
months.
Good guess. That's a good guess. Okay, so how do we know that? Well, okay. So in the real world, right? Or in a CCA exam, you're like, oh my God, I don't know this, right?
Okay.
Make sure you know where your guidelines are in the E&M, well, in any section of the book, right? Of the CPT code book. So the guidelines, when I say guidelines, so this I'm on page
4.
4. Yes, thank you. And they're kind of shaded this green color. See how they're kind of green? And so the code pages are white, but the guideline pages are always going to be kind of green. Um, and so there's like 14 pages of E&M guidelines. New versus established patient guidelines is on page 6, and there's a flow chart or a decision tree to help you determine whether or not a patient is new or established. Um, it says, has this patient received any professional service from the physician or other qualified healthcare professional or another physician or other qualified healthcare professional in the same group of the same specialty within the past 3 years? And so in this case, and I'm showing it here, you can see, and make sure you're highlighting or underlining, putting stars around things that are important in your book to make sure that you kind of can pull those out visually when you need them. So 3 years. So this patient was seen 2 years ago, but the new patient qualification or guideline is 3 years, right? So because she's been seen within that 3-year time frame, she is going to be considered an established patient. Does that make sense? Did I say that right?
Yeah.
Okay. Okay, so we're gonna call her established. Okay, last question, setting of service. Now, sometimes it's different. Sometimes it's the same. So in this case, it's an office visit in the office. So the setting of service is the same. It could be type of service as a consultation in the office, or it could be a preventive service in the office. But in this case, it's an office visit in the office. So sometimes, you get an answer that's different. Sometimes it's the same. Sometimes you don't even get an answer. Okay, so these 3 things are going to help us identify or narrow down the code range, and then we're going to figure out if we're using and notice we're kind of getting into the book already. We haven't even read the note yet, right? And we've only read the first two sentences. So we're going to narrow this down, and then we're going to dig into the note. So if you go to page 1 in the CPT code book, I like to teach E&M coding based off of the table of contents because I think it really corresponds well to these questions, right? So on page 1, in the middle of that page, there's a black heading that says evaluation and management. This is where our codes start. And I always say this, but look at the colors, right? They don't do this just to be pretty or colorful. Green is a heading, red is a subheading, blue is a subcategory, right? Like, so you have all these things. So you can see in green, it says other or office outpatient services. Did I say that right? Office or other outpatient services. And the next heading is in green is telemedicine. So we know that this is an office visit, right? So we're going to start right there already. We already know that our code range is going to be 99202 through 99215. We're already kind of narrowing it down, right? So underneath that in red, we have
Because it's less than 3 years.
Yes. So she's established, right? Because it's less than 3 years. So you're going to click that, or you're going to kind of go down to that established patient, which is going to give you a code range 99211
Right.
through 99215.
You can only
This.
find that here, correct?
Yes. And so you're going to want to go. Hang on, I'm messing with my screen here. Okay. So you're going to want to go to page 16. Another little tip that I like to give is when you're tabbing your books, because there's so many guidelines for the E&M section, it can be hard to like find where the E&M codes start. So I like to put a little yellow tab on page 15 or 16, just so that you can like flip right to it because it's really fast that way. So page 16, let's look at 992. So 99211 is that's what we call a nurse visit code. So you can see the code description on page 16, 99211 says office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. So this is like a nurse visit code. So this is when there's no medical decision making, there's no time requirement. This is if like you go in and the patient gets blood pressure or does like a weight check or something like that. But so yeah, we don't need to worry about that one. Let's start with 99212. 99212 on the right-hand column on the top says office or their outpatient visit for the E&M of an established patient. We got that, which requires a medically appropriate history and/or exam and straightforward medical decision-making. And then under that, it says when using total time on the date of the encounter for code selection, 10 minutes must be met or exceeded. So that's where our time frame is, right? So here we're looking for time spent, right? So we know 99212 is at least 10 minutes. So let's go back to the note. And so in the real world, when we're coding based off of time, typically doctors will document their time spent at the bottom of the note. So I always just go straight to the bottom of the note. If I'm ever looking for time spent, it's almost always at the bottom. I don't know if I've ever seen it anywhere else other than the bottom of the note. Excuse me, but it's usually at the bottom of the note. Okay, so here I'm just going to scroll all the way to the bottom of the note. And it says, I spent 25 minutes reviewing her previous mammogram and biopsy reports, her previous records, and discussing treatment options with Jane. 25 minutes. Okay, so going back to my book. Okay, so 99212 was 10 minutes. 99213, that's 20 minutes. 99214 is 30 minutes. So in this case, we can't get to 99214 because we haven't reached that 30-minute limit, right? So we have to go down, even though, 99213 is 20 minutes, we got 25. So we've gotten a little bit more than the minimum, but we have not exceeded that 25 minute or that we have not exceeded it so much to go to 30 minutes. If I'm saying that right? We're not at 30 minutes, so we have to code it at 99213. Oh, sorry. Okay, so if we're coding this based off of time spent, it's going to be a 99213. Does that make sense so far?
Yes.
Okay, cool. All right, so this next one is the harder one. Number 2. What is the appropriate CPT E&M code when determining it based on the level of medical decision making? I'm going to make this pink or something, green. Okay, so same encounter. We know we're going to be in the same code range. It's not going to change anything. It's still an established patient office visit. It's going to be a 99212 through 99215. But now we need to figure out what is the medical decision making supported by this encounter, by this documentation, and then figure that level out. So what I have opened up, and I attached this to the announcements and in the discussion last week. This is the medical decision-making table.
Okay. I'd like to grab that. Can you hold on a second?
Yeah, hang on. I'm trying to find one that's a little bit bigger. I thought I had one that was a little bit bigger, but I guess not. Let me get it, try to make it as perfect as possible.
I feel like I have it, but I don't know. So hold on.
Oh, and let me go up a little bit. Hang on. Because we still have high over here. And again, you should, I sent this PDF as an attachment. What I would suggest, especially as you're learning, and I really like to teach medical decision making based off of this table. I'm a really visual person, so it makes sense to me, right? But if you do that too, right, I would suggest maybe printing one of them out and putting it in like a little laminate sheet,
Right.
so that you can draw on it, right? You can like, and I'm actually going to do the same thing. Let me get a snip.
Hold on, hold on, hold on. Did I download them? Oh wow, that's tiny.
It is small.
I'm gonna blow mine up because I'm blind as all get out. I kind of like having you to myself, to be honest with you.
It's nice, right?
I do.
It's good to just, I usually just kind of talk and talk and talk with not a lot of feedback. So it is good to have someone out there to talk to. Um, okay, so yeah, I'm gonna go back to I'm just gonna go to the snip that I made. Um, Actually, no, I'm not. I'm gonna go to this because I can actually blow it up a little bit.
Is it the same one?
It's the same
Yeah.
thing.
Okay.
Okay,
Okay.
so this is the table. I blew it up. So this will be a little bit of a repeat from last week, but it bears repeating. Um, so the MDM table is how we identify a level of medical decision making, straightforward, low, moderate, or high, and you can see that level on the left-hand side of the screen.
Right.
And that level is based on 2 out of 3 elements of
But you know
MDM.
what I don't see is the code on the one that I grabbed from.
Oh, that's that. Yeah, that's okay. It corresponds. So a level 2, so you'll notice the 99202, 99212, that's going to be
Uh-huh.
straightforward. A 3 is a low, a 4 is moderate, and a 5 is high. And
Okay.
that's for either new patient or established patient office visits. So this, um, yeah, I guess I have 2 different versions. So this one with
Yeah.
the actual code on it is only for office visits, but the levels, straightforward, low, moderate, or high, are going to be elements for any kind of E&M service, right?
Okay.
Um,
Okay.
it's just that this one has those office visit codes
I
on
like
it.
that one better than the one we have
Yeah,
here.
it's pretty nice. This is way easier, believe it, than it used to be.
Where did you find that at?
I don't know.
Can you send it
I
to
didn't
me?
I didn't realize it was different. Yeah, I can send it to you. Um, okay, so how do we get to that level, right? Straightforward, low, moderate, or high. That is based on 2 out of 3 elements that meet or exceed that level, right? So let me zoom out a little bit. So if I have low number of complexity of problems addressed and limited amount of data, then that's 2 out of 3 at that low level. That's 2 out of the 3. It's going to get low MDM. Same thing with moderate. If I have moderate diagnosis and moderate risk over here, that's 2 out of 3 at that moderate level. That's moderate MDM, right? It's not quite that simple because you can have any number of levels of different things, and sometimes you have to figure out how to add it up. So let's, where am I at here? Where's my snip? Okay, so I'm going to go back to my snip. And I just took a snip just so because I can draw on this. And now when I do E&M coding, I like to start off on the very left-hand column, which is our number and complexity of problems addressed, which I like to call the diagnosis column. This is where we qualify and quantify our patient's diagnoses, right? Meaning, what's the quality? Is it chronic? Is it stable? Is it complicated? Is it uncomplicated? Is it worsening? Is it severely exacerbated? Right? So what's the quality? And then quantify in terms of how many what's the quantity? How many are there? So you can see in this minimal level, you've got one self-limited or minor problem. At low, you've got 2 or more self-limited or minor problems. In terms of chronic illnesses, we have at that low level, you have 1 stable chronic illness. But then what if the patient's got 2 stable chronic illnesses? That brings us into that moderate level. What if that chronic illness is exacerbated? Asthma with exacerbation, anxiety with panic attacks, right? Progression or side effects. And then going down, I'm not going to go through all of this because we do not have enough time for this. At high, it would be 1 or more chronic illnesses with severe exacerbation, progression, or side effects, right? So this is, again, that diagnosis column. So let's go to our encounter now and figure out what has this patient got in terms of diagnoses, and then we can at least figure out what's her level in terms of diagnosis. Okay, so we looked at the first 2 sentences here. Let's look at sentence number 3. Three and four. A diagnostic mammogram and stereotactic core needle biopsy confirmed carcinoma of the left upper quadrant breast. That would be considered a chronic condition. Um, it looks like her medical history includes depression managed with Zoloft and hypertension managed with lisinopril, and family history includes a mother with breast cancer. So this depression and hypertension, if I was coding this, I wouldn't count this because it states medical history. It doesn't specifically state that they are current conditions. So I wouldn't really capture that. But we do know that this patient has confirmed carcinoma of the left upper quadrant breast, which we're going to consider a chronic condition, and it's recurring, right? So she completed treatment 2 years ago, and now it's recurring. So that's pretty much all I think I need to know to call this a
Moderate.
a moderate diagnosis, one or more chronic illnesses with exacerbation, progression, or side effects. So it's coming back. That's a progression of that disease, right? So we're going to call her her recurrent breast cancer diagnosis, a moderate diagnosis because it's coming back. And at this point, she's just now coming back for it. We don't know if it's stable, right? We haven't even done any labs. We've just barely gotten her figured out at this point. So moderate. Now let's look at data. Scrolling over. So this middle column is the amount and or complexity of, oh goodness, data to be reviewed and analyzed. This is going to be where we identify all of the different data points and information gathering that the provider did in order to to complete medical decision making for this encounter. So this first category, so I'm not going to go like way too much into this. Limited, so minimal or none at that straightforward level, that would be one or fewer tests ordered or reviewed. Limited level is going to be any combination of two. So usually that's going to be like ordering or reviewing the results or reviewing external notes. At least two tests, ordering like a urinalysis and a urine culture, right? That's two unique tests. So minimal is one or fewer data points. Limited is 2 data points. Moderate is 3 data points. So you would have to have 3 different tests, 3 different things you're reviewing. Obviously, we've got some other stuff here. We've got independent historian, independent interpretation of tests, discussion of management or test interpretation with another clinician or appropriate source. Again, we don't have time to really go into that. So let's just go back and then, yeah, extensive is the same thing, but you have to get 2 out of 3 of those categories. So extensive data, we usually only see in, I see it much more in inpatient setting. Okay, so let's go down here and see what kind of data we're gathering. Second paragraph, on review of systems, Jane denies constitutional symptoms. I'm going to skip through this because pretty much it's all negative. She is currently tearful, consistent with her psychiatric history. Next paragraph, physical examination revealed a well-nourished female, normal vital sign, blah, 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 blah. Examination revealed tenderness and a palpable mass. And then next paragraph. So I'm just kind of, for the sake of time, skipping through this. Discussion ensued regarding treatment options. Considering the recurrence, a modified radical mastectomy with axillary lymph node removal is recommended. A PET with CT scan was ordered to evaluate metastasis. Referral to a plastic surgeon for breast reconstruction post-mastectomy was advised, and psychological support was recommended, and Jane agreed to the surgery. So I'm going to make that green. So it looks like we are ordering a PET scan with a PET with CT scan, which is a data point, right? That's a lab. It's not a lab. It's an imaging service. Where's my snip? There we are. Okay, so we ordered one thing, one test. She's a cancer patient, but we didn't get 2 or more things. So we're way up here. We're minimal or none. She is at that straightforward level when it comes to data. Uh-oh. So, and that's why I said, like, this, it's not always that easy. Sometimes they don't match up. So here we have moderate diagnosis. We have minimal data. So where are we going to go now? So we have to go to this risk category to find the tiebreaker, right? What level of risk are we looking at here for this breast cancer patient? So I'm going to go here. Okay, so last column, risk of complications and or morbidity or mortality of patient management. This is what I like to say. If the patient were to go home today without being treated, how risky is this condition to this patient? There's also another consideration when we're talking about risk is how risky is the additional diagnostic testing or treatment, right? So not only just how risky is the condition to the patient, but how risky is it for us to potentially treat or continue to test this patient, right? Um, Minimal risk is going to be essentially go home and take a nap, right? Go home. If it's a bug bite, don't scratch it. Maybe put some lotion on it, right? Minimal risk is going to be patient's going to be okay. Low risk is where we see over-the-counter medications, potentially vitamins, supplementation, wound care, an ACE bandage wrap. Usually we're going to see things like referrals to specialists fall into the low risk category. So like a referral, patient's got hypothyroid and it's, her levels are funky. And so we're going to refer to an endocrinologist. That would be low risk. Moderate risk, we finally get some examples, thankfully. A really big one here is prescription drug management. Prescription drug management is any kind of drug management, stopping, starting, or changing a prescription, or even continuing a prescription, excuse me, exactly how it is right now, right? Because that still means the doctor has determined that that current prescription is sufficient to manage that patient's condition at that level, right? That's all medical decision making. We have some surgical procedures here, and then we have social diagnosis or treatment significantly limited by social determinants of health. Those are going to be things like low income, lack of access to transportation, they can't come to their appointments, crazy things like sibling rivalry, empty nester syndrome, stuff that's going on in the patient's life that's impacting their healthcare or their ability to access healthcare. But remember, talking about some surgical procedures here. So as we just read, this patient has agreed to undergo a modified radical mastectomy with axillary lymph node removal. So going back here, look at these, we have surgical procedures, right? Second bullet says decision regarding minor surgery with identified patient or procedure risk factors, or decision regarding elective major surgery without identified patient or procedure risk factors. A mastectomy is an elective major, an elective major surgical procedure. So it very clearly is going to fall in
A
right
mastectomy is
here.
elective? That's not like a.
She doesn't have to do it, right? I mean, she could decide to treat it. She could just say, no, I want a lumpectomy. She could say,
I
no, I only want
gotcha.
radiation, right? So yeah, it is an elective major surgery. Um, I would just hope she elects to do it, right? But
Right,
not all
right,
patient,
right. That's
not all
what I was
patients do.
thinking.
Um, and so that very clearly puts her in that moderate risk category. So we have moderate diagnosis, moderate risk, 2 out of 3 at that moderate level. It's going to be moderate MDM. Okay, all of that. To determine that a patient has moderate medical decision making. Now that we've identified the level of MDM, let's go back to the book and figure out what code would be applied. 99212, as we saw, is straightforward. And what I would suggest is if you haven't done it so far, you can maybe see it. I've highlighted like the word straightforward is yellow, and then 10 minutes, and then low for 99213, and then 20 minutes or whatever it is, 20 minutes, and then moderate, and then 30 minutes, right? So that you,
Okay.
again, can write in your book, highlight, star it, underline it, whatever you want to do. But it really helps to kind of pull that information out for you. So
Okay.
99212 is straightforward, MDM. 99213 is low MDM. 99214 is moderate MDM. If we flip the page, you can see 99215 is high MDM. We definitely didn't get that. If we go back to, oh, I wrote it down. Yeah, so we have moderate MDM. So in this case, you want to tell me what would our code be if we were to select it based off of the level of medical decision making?
99214.
Yeah. Oh, my number lock came off. Hang on. Here we go. 99214. Okay, so there's probably a question mark in your brain right now. Good job, by the way. So we got
Thank
level
you.
3, a 99213 for the time, a 99214 based on MDM. Okay, now let's look at number 3 here. It says, what is the accurate E&M code for Jane Smith's visit with Dr. Wells? All right, well, how do we know? We got a level 3, we got a level 4. What do we do? According to CPT guidelines, we can base an E&M code off of either MDM or time. So what we want to do is we want to report the code that most accurately represents the work involved in that encounter, in which case it's going to be the higher level, right?
That's what I was thinking. Yeah.
Yeah, because it's we don't, and I have to be really careful what I say. I don't want to say because we can charge more, right? But that the truth is it does hold a higher charge, but it corresponds to the actual level of work that was performed on that
And care.
encounter.
I mean, the actual level of care that's being given to that
Absolutely.
patient, correct?
Absolutely.
Okay.
Absolutely. So
So
whenever,
is that a like a standard? You just go with the higher one? I mean, if it makes sense, you go with
yeah,
the higher
yeah.
one.
Yeah,
Okay.
go with the higher one. I actually still talk to a lot of doctors who say, "Oh, if time's documented, I have to code it based off of time." So that's kind of a common misconception for some reason, but that's absolutely not the case. You would report
Okay.
the higher code because it more accurately represents the service that was performed, right?
Right.
Whether the time is higher than the MDM or the MDM is higher than the time, right? Report whichever one is the highest.
Okay. Gotcha.
Okay, so that's week 3 portfolio project, pretty much done. Number 4 does have, there is a rationale here that you're gonna want to explain, why you selected the code you selected. And I always say, don't just put the steps to coding here. Give me a step-by-step breakdown of how you coded this, right? And I like to say in
Okay.
at least 75 words. I don't think it's on this, but yeah, give me a good few sentences at least, right? 3 or 4 sentences. Just tell me how and why you selected the code that ultimately you selected.
Okay.
Okay. So we have about 8 minutes left. We're doing pretty good on time, actually. So I'm going to go back to Blackboard and we're going to switch gears and we're going to go to the discussion.
Hold on, let me get there.
I'm going to copy this. All right, now we're all on one page. Okay, so switching gears. I'll probably go over a little bit, but I'm going to try not to. Okay, so
Okay.
this week we're talking about in the discussion, we're talking about radiology and laboratory services.
Okay.
Um, and last week we did E&M. This week we're doing radiology and lab. And so remember in the CPT codebook, we have 6 sections. We have E&M, which we did last week,
Right.
anesthesia, which we'll do at the very end of class. Surgery, we're going to spend, after this week, we're going to spend a couple weeks in the surgery section. Radiology and lab and medicine, right? So we have these 6 sections. And as we go through these 6 sections, it helps to kind of put your, well, they're organized differently, right? Because they're different types of services. So it helps to put yourself in a little bit of a different mindset, I think, as you're coding these things out. Radiology, essentially, it's the vast majority of stuff in the radiology section are diagnostic procedures, meaning we're doing them to get a diagnosis, right? Does the
Right.
patient have a fracture? Does the patient have a gallstone? Does the patient have, what's the status of the fetus, right? Like your ultrasound procedure. There are some radiation oncology procedures in there, but we're not even going to touch those in this class. That's really, really specialized. Okay, so sorry, I went blank there for a second. When we're coding radiology, and I like to have us do this for pretty much every section, right? Ask yourself questions when you're kind of abstracting this note to say, how am I coding this, right? The first question you want to ask yourself is, what service was provided, and maybe I should even say what imaging service was provided. Um, was it an X-ray? Was it an MRI? Was it a CT scan? Right? Like what kind of procedure was it? And that's going to be what you look up in the index. Computed tomography or X-ray. A funny thing about X-ray is you will find the term X-ray in the index, but you will not find the term X-ray in the actual main section of codes. They call it a radiologic examination, which I
Okay,
always thought
that's
was
good to
kind of
know.
funny. They just don't call it an X. They call it an X-ray and then they don't call it an X-ray. I always thought it was a little funny. So this is going to be what you look up in the index, right? So we didn't even read the case yet. I should read that. So in this case, case one, we have a patient went to Vista Imaging Center and Dr. Smith performed a CT imaging of the left leg with contrast. Vista Imaging Center is a facility where the radiologists own the equipment and read and interpret their own studies. What is the appropriate code and modifier if applicable? Okay, so first question is, what was the service provided?
CT scan.
Right. Here, right. Yeah, I like to try to highlight things to keep myself together. Okay, so we
Right,
have a
right.
CT scan. That's going to be what we look up, right? Next thing we look up in the index is what area of the body was imaged, right? So
Left
we did
leg.
a CT scan. Was it the whole body? No, you could potentially do there are some services that do the entire body. But in this case, it's just the leg, right? So
Yes.
that's going to be the next thing you look at. And then another really important thing when it comes to diagnostic radiology is what was the laterality, I guess I'm going to call it. Laterality meaning which side was it on, right? So in this case, it was the left leg. And so we have modifiers for laterality. I'm going to say add the laterality modifier. LT for left, RT for right, or 50 for bilateral. And I'll post all this online too, so you have all of this bilateral. Okay, so whatever we do in this case for this patient, right? For this CT of the left leg, whatever that whatever that procedure code is, we want to make sure we add modifier LT to specify that it was a left leg. In the real world, you also want to make sure that we have a diagnosis code that corresponds to that laterality and area, right? So like if I work with denials all the time, right? And so like if I'm coding for a CT scan of the left leg and it is sent with a diagnosis code for an unspecified leg, the payer is going to get that and they're going to say, this doesn't make sense. And they're going to kick it back and deny it, right? So laterality modifier is really important when it comes to diagnostic radiology, as well as a corresponding diagnosis code with that same specificity. Next question. Okay, what do we got here? So we have imaging, contrast. I should say administered. Administered. Okay, so contrast is it can be a form different. There's lots of different types of contrast. Contrast can be something that's swallowed, it can be something that's inhaled, it can be something that's injected into the patient. When it comes to CPT coding, the only time that contrast counts for coding purposes is if it is injected. So must be injected. I'm going to say intrathecally, intravascularly, or I can't spell these things. Intra
Venously?
intra arterially. Am I getting this right? Sorry, now I'm second guessing myself. Yes, there's intravenously. The guideline for this, excuse me, is at the beginning of the radiology section of the CPT code book. And it's those kind of green shaded pages. It starts on page 524, but the one that I'm looking at is on page 525. And there's this little section, and again, it's on the green shaded section. There's this little section on the bottom left hand corner, sorry, says administration of contrast material. It is vascularly. I was all messed up. It's been a long
You
day.
said 525?
Yes. Okay, so yes, as far intra-arterially, it has a hyphen in it. That's what was messing me up. Okay, so again, on page 525, on the bottom left-hand corner of that page, it says administration of contrast materials. The phrase with contrast used in the codes for procedures performed using contrast for imaging enhancement represents contrast material administered intravascularly, intra-articularly, or intrathecally. So essentially, they're all injected into the patient. Vascular is into the vasculature, arterial is into an artery, intrathecal is into a joint, right? So these are going to be things, again, that are injected into the patient. So if a patient breathes something in, or if they drink something, yes, it's contrast, but for coding purposes, it doesn't count, right? So contrast, what is it and what does it do? Contrast helps just enhance and sometimes give different images, different views of that image, right? So sometimes they perform a procedure with contrast, sometimes they perform it without contrast, just depending on what they need or what kind of view they're looking for. And then sometimes they can do it with and without contrast. So you're going to see in the code descriptions, it will say without contrast followed by, sometimes it'll say like additional series with contrast, something like that. It's very wordy. But essentially, it says you have to do it without contrast, then they administer the contrast, and then they do additional series, right? So you have those three different differentiations: with, without, and with and without. A good important or a thing to note here with this contrast is that not all X-ray services or not all radiology services are applicable. Contrast isn't applicable, right? So if it's not included in the code description, don't even worry about it, right? So up here, excuse me, it says with contrast. So when it comes to the code selection for this code, you're going to want to make sure that you select the CT of the left leg with contrast. Okay, we're not done yet. This keeps going for a minute. We're going to keep going for a little bit. Number fourth question is number of views. Now, views do not come into play when it comes to CT services, but it does come into play when it comes to X-rays. A view is essentially like how many different directions are we taking this X-ray from, right? If I scroll down to case number 4, case number 4 here is a radiology case for our discussion. It says a patient went to an outpatient hospital imaging center and received a 3-view chest X-ray, right? So in this case, this X-ray, if you have case 4, right, you're going to want to make sure you select the one that has the 3 views in it. But up here, when it comes to CTs, the concept of number of views doesn't apply to CTs. So you don't worry about it, but it's a good question. You always have to look for it. Okay, last thing. component coding. All right, so this is going to take me a minute. Component coding is, so let's say we have, when my daughter was 4 years old, she fell off the monkey bars, broke her wrist, right? This was a Friday afternoon. I go pick her up at school, and there's the doctors are all closed, right? So I had to take her to the urgent care. Now this urgent care was a freestanding urgent care facility. They have an X-ray machine. They employ the X-ray technologist who takes the X-rays, and they have a doctor on call who reads and interprets those X-rays, right? Sorry, it's getting some crazy wind. And so in that case, the urgent care facility did the entire service. They did the entire imaging service, right? Okay, that's one example. Now, let's take another example. Let's say we have a patient, she lives in a small town, she's got a high-risk pregnancy, she's pregnant, right? She goes to her OB, and her OB says, we need to get an ultrasound. That provider does not have an ultrasound in the office. So she sends this pregnant patient to the imaging center. The imaging center gets the order for the ultrasound. She goes to the imaging center. They do the ultrasound on the belly. They record it. They don't put it on a disc anymore, but they upload it to the interwebs or whatever. Those findings go to the doctor who ordered that ultrasound. And then the OB-GYN who ordered the ultrasound, then reads and interprets the ultrasound recording, the findings, right? So the first example was where we have the global procedure. If I could type, it would help. The global procedure is when
procedure was when they did everything in the one building, correct?
Everything, right? That facility owns the equipment. They pay for the X-ray tech. They also pay the salary for the radiologist or the provider who reads and interprets the X-rays. That's the whole thing, right? On the other hand, on the other example, we have the OB provider who does only the professional component,
right?
Who's only reading and interpreting, and then that imaging center. I can't type it. Technical. The imaging center. It's been a long day. I apologize. The imaging center does only the technical component of that procedure, right?
And then they forward the information to the professional who reads it.
Yes.
And that's how it's coded. Okay.
Yes. And so the way we do this, right? Like, how do we code it, right? So the global procedure, you bill for the entire CPT code with no modifier. Or I should say no component modifier, because you might still need an LT or an RT, something like that. And when you send it with no component modifier, the payer will pay the whole thing, right? Because you did the whole thing. For just the professional component, you want to send it with modifier 26. So you'd report the same CPT code, but with modifier 26. What that's going to do is it's going to result in about a 40% payment amount for that CPT code. Because you didn't do the whole service, right? You didn't. Right. So you add modifier 26, you get a reduced payment because you didn't do the whole thing. On the other hand, technical component, you add modifier TC, and modifier TC, interestingly to note, is not in your CPT code book. So I would suggest you add it, and I'll show you where to add it here in a second. So adding modifier TC, again, it breaks it out so that you don't get the 100% payment for this. You get paid about 60%. Payers will pay a little bit more for the TC modifier because the technical component, X-ray machines, MRI machines are very expensive, right?
Yeah.
And so, yeah, that's your components. So where do you add this modifier TC? Modifiers are listed in Appendix A.
All the way in the back.
It's on page 969, and it's Appendix A. It lists all of the CPT modifiers. At the end of Appendix A on page 975, it does list out some HCPCS modifiers. So again, it's on page 975. You've got like eyelids, fingers, toes. Yeah. You can see you have the LT modifier. If you flip the page, you'll find the RT modifier. TC is not in this list. So I would suggest that you add TC to the list, just so you have it. I honestly don't know if it's on the I don't think it's on the CCA examination, but it's good to know, right? And so I would just, there's actually a really good area to write on this page, page 976. So I like to have students write TC for technical component. That way
Yeah,
you
I
just
got
know that it's
it
there.
there. I put it there. I just put it off in the margin, right?
Yeah, that's fine. And that,
It's
in a
not
nutshell,
one.
is radiology coding.
Okay.
Oh, wait, we're not done here. Let's go back to case number 1. So while you're doing that, I'm going to keep reading. Vista
Okay.
Imaging Center is a facility where the radiologists own the equipment and read and interpret their own studies. So what this sentence is describing is the global procedure. So here you would not add a component modifier. We don't have enough time to actually code this out because I want to talk about lab coding really quickly. But yeah, that's in a nutshell radiology coding.
Okay.
If you have, those of you watching the recording, if you have case number 4, pay attention to the last sentence on case number 4. It says, what is the appropriate CPT code and modifier, if applicable, for coding the technical component of the chest x-ray? So pay attention to that part of this case scenario. It's wanting specifically what modifier would you add for just that technical component. Okay, let's switch gears really quick again. We're going to talk about lab coding and then we'll be done. I know I'm 10 minutes over, but there's just so much for week 3. It's impossible to do this in an hour. Okay, so switching gears, we did radiology. Now let's talk about labs. Lab coding, again, it's its own complete section in the CPT codebook. You have to put yourself in a different mindset. We're not doing things to patients. We are testing pieces of patients, right? If that makes sense, right? We're not doing the biopsy. We're not taking the, I don't know, tissue sample or anything like that. We already have the samples. They're in little cassettes or in little Petri dishes or whatever they're in. We're just testing those samples, right? So you're not going to find surgical procedures per se in the lab section, right? We're assuming we already have those pieces of patients. Case number 2, a patient went to his primary care office and had his yearly exam completed at his physician's office. His primary care ordered a basic metabolic laboratory panel, with calcium total test to be done. I'm gonna highlight that green. Okay, so basic metabolic panels. So I'm just going to show you where the panels are. Panels are a really important component because they're very, very common. The Path and Lab section of the book is blue. Panels start on page 602 in the CPT codebook. And so a panel is basically, it's again on page 602. It's a group of codes that are commonly a group of labs that are commonly performed together to kind of give us a view of a patient's anatomical functioning, right? So you have like metabolic panels, general health panel, electrolyte panel. You've got some like obstetric panels, lipid panels, that kind of thing. Most of them are made up of at least 4 or 5 different lab tests. And so they bundle them into a panel just because it's easier to report one code than reporting 15 different codes, right? So if you look at the first panel code 80047, that's a basic metabolic panel with calcium ionized. This panel must include the following: calcium, carbon dioxide, chloride, creatinine, glucose, potassium, sodium, and urea nitrogen, right? So that's 8 different lab tests that all go in to make this panel. So we do all those lab tests instead of reporting them piecemeal. We just report CPT code 80047, and then that's all together, right? Important to know about the panels is it's all or none, right? So if we do all 8 of those, then yes, we can report the panel. If for any reason even one of those is missing, it breaks the panel apart and you have to itemize them out, right? You have to list them individually.
Goodness.
Yeah, and they're very, very common. This is like when you go to the doctor and you go to your adult medicine provider and they do your labs, they very common will do a full panel. And they're so they're really common in primary care. Um, so that's panels. Number three, and then we're almost done. Number three, a patient went to his local hospital to have his laboratory work completed. His blood was drawn via a routine venipuncture to determine his total testosterone level. What CPT codes would be assigned for the venipuncture and the lab test? Okay, so now this is also a really, really common scenario, right? So if you've ever gotten labs drawn, blood labs, whether sometimes they'll do the blood draw at your doctor's office and take the little tube of blood and send it to the lab, right? If that's the case, that's the venipuncture. If that's the case, the doctor will bill for the venipuncture. More commonly, though, the patient goes to the lab and the lab technician will do the venipuncture and also test the blood. So that's kind of what's going on in this scenario here. We're doing both the venipuncture. Oh, I'm going to highlight this one. Hang on. Oops. So we're going to need two codes. One for the routine venipuncture, which is technically then, hang on, venipuncture. I can't type these things and talk at the same time. I really can't. You're going to have two codes. Venipuncture. Okay. Technically, venipuncture is a surgical procedure. It doesn't seem like it should be because it's kind of not that big of a deal, most people think, but it is a surgical procedure. So that's going to be a surgery code, right? It's in the cardiovascular surgical section of the CPT code book. You're going to look for routine venipuncture. And then you're also going to have the code for the lab that they performed on that blood, right? Testosterone. Did I spell that right? So if we
Yes,
have
you did.
case 3, you're going to have two codes. That's going to be the only one for this discussion this week where you have two codes. And that, in a nutshell, is lab coding. There's a lot more to lab coding, but we don't have time for that. And I know we're all probably mentally exhausted at this point because this has been a lot of information. So before I kind of adjourn, do you have any questions, comments, concerns about week 3 so far?
I do not.
We'll see how it goes, right?
Yeah.
Okay, well, thank you for being so interactive. It's nice to have somebody to talk to on my calls. So if you need anything over the course of the week, please reach out to me via email. And yeah, other than that, have a good week 3. Happy coding. Give yourself some grace because week 3 can be kind of rough.
Okay.
So just, you're good. At least you have the live web call done.
Yeah.
Right.
I appreciate you. Thank you so much.
Yeah, you're welcome. Have a great night.
You as well. Bye
All
now.
right, thanks. Bye.